Radiotherapy sits right at the centre of modern cancer care, used across curative, adjuvant, and palliative settings. But the thing that always sets the boundary is normal tissue. This review by Deborah Citron and Robert Timmerman is essentially a guided tour of how radiotherapy has become more precise, how that precision has reduced the incidence and severity of side effects, and what we're learning about the biology of injury, especially things like senescence, inflammation, vascular change, and fibrosis, that may unlock more personalised approaches to preventing and treating toxicity. I'm selfishly excited about this one because it's the kind of review that can spark very practical research questions, especially around prediction and mitigation. And they're the kind of research questions that if we really sink our teeth into, they could make a genuine difference for patients. So I just had to choose this one for the further reading series, even though it's a review and not original research as I normally discuss here. If you're here for papercraft, I will still include a little section of that at the end, but fair warning that most of this video actually does focus on the topic of the paper, so radiotherapy in normal tissue. So the authors start by separating radiation side effects into acute effects during or shortly after treatment and late effects that can appear months to years later, sometimes after a latent period where acute symptoms have resolved. Acute effects are often tied to stem cell depletion in rapidly turning over tissues like mucosa and skin, or acute inflammatory reactions such as pneumonitis, and they're typically time limited. Late effects are less predictable and can be chronic, involving vascular injury, distorted tissue architecture, chronic inflammation, fibrosis, and loss of organ function. They also make a key practical point. Acute toxicity doesn't reliably predict late toxicity in the same organ or patient. You can have one without the other. And importantly, underuse or refusal of indicated radiotherapy is associated with worse cancer outcomes, so understanding and reducing toxicity isn't just quality of life, it's part of delivering effective cancer care too. Across the paper, the recurring first principles predictors are dose, fraction size, total dose, and critically the volume of normal tissue irradiated, with additional risk from comorbidities, reduced baseline organ function, impaired wound healing, prior surgery, genetic predisposition syndromes, and concurrent radiosensitizing chemotherapy. Dose constraints are fractionation specific and sometimes depend on substructures within an organ, and many constraints were empirically derived and updated over time. Figure 1 is doing a lot of work. It uses prostate radiotherapy to show how the field moved from 2D planning based on skeletal landmarks to 3D conformal planning using volumetric imaging, and then to IMRT, VMAT, and stereotactic ablative radiotherapy, where dose can bend around concavities and avoid adjacent normal tissues. Now, the key conceptual tool here is the dose volume histogram. Instead of thinking only what dose is delivered, we ask how much of an organ receives each dose level. The figure also highlights a practical intervention, placing material to create space between the prostate and rectum, which further reduces rectal dose when the prostate seminal vesicles are targeted. This is one of those figures I love because it compresses decades of technology through to biological outcome into a single visual logic. It's so nice. I want to pause here briefly to clarify some terminology that comes up a lot in radiotherapy papers, and I'm about to mention it here. So words like conventional, hypofractionated, and ultra-hypofractionated get used very casually once you're inside the field. Fractionation simply refers to how the total radiation dose is divided over time. So in conventional fractionation, the total dose is delivered in small daily fractions, typically around 1.8 to 2 gray per day over several weeks, usually Monday to Friday for each week. This approach was historically designed to allow normal tissues time to repair between doses. Now, hypofractionation means using fewer fractions, each at a higher dose, shortening the overall treatment course. Now, this is now standard in several different disease sites, including breast and prostate cancer, where long-term outcomes and toxicity profiles have shown to be comparable to those conventional schedules. Ultra-hypofractionation, as the name suggests, takes this a step further, so very few fractions, each delivering a relatively large dose. Stereotactic treatments fall into this category. These regimens rely heavily on precise targeting, image guidance, and motion management because the margin for error is much smaller when each fraction carries so much biological weight. So when you see these terms in papers like this one, they're not just describing convenience or scheduling, they reflect very different assumptions about tissue repair, dose tolerance, and how tightly the radiation can be confined to the target. The authors then broaden from prostate to general advances, better tumor delineation via CT and other volumetric imaging, functional imaging like FDG PET, helping to reduce elective volumes in some settings, motion management and image guidance, reducing margins, hypofractionation and ultra-hypofractionation becoming standard where outcomes and safety compare favorably to conventional fractionation, and charged particles like protons offering Bragg peak depth dosing with no exit dose, with ongoing trials comparing proton and photon approaches. So before moving on, I want to pause a moment on a concept that comes up whenever people talk about proton therapy. It's genuinely useful to understand, and it's that term that I just mentioned, Bragg peak. So whenever we deliver conventional radiotherapy using photons, X-rays, the radiation deposits dose as it enters the body and continues depositing dose as it passes through the tumor and keeps depositing dose on the way out. So there's always an entrance dose and an exit dose. But charged particles like protons behave very differently. As the proton travels through tissue, it loses energy gradually at first, but as it slows down, the amount of energy it deposits rises sharply, reaching a maximum just before the proton comes to a stop. That sharp spike in energy deposition is at a specific depth, and that's what we call the Bragg peak. That's super, super important because beyond that depth, the dose drops to pretty much zero. There's essentially no exit dose. So by choosing the energy of the proton beam, clinicians can actually control where in the body that peak occurs. So then the highest dose is delivered within the tumor rather than beyond it. And because real tumors have thickness, not just a single depth, multiple Bragg peaks at slightly different energies are layered together to create what's called a spread out Bragg peak, which covers the whole target volume. This physical property, it's not a biological property. This is why proton therapy has the potential to spare surrounding normal tissues in certain anatomical situations, particularly when critical structures sit just beyond the tumor. Figure 2 introduces a deceptively powerful idea. Organs behave differently depending on whether their functional subunits are arranged in parallel or in series. In parallel organs like nephrons in kidneys, alveolar units in lung, you can lose a portion and still maintain function if enough volume is spared. In serial structures, the classic example would be the spinal cord, even focal injury can be catastrophic for function. That's why highly ablative focal treatments tend to be safer when the geometry and biology allow spare capacity or compensatory repair, and why central targets near serial structures are approached with particular caution. Figure 3 is the mechanistic spine of this review. Immediately after radiation, energy deposition causes direct damage and indirect damage via reactive oxygen species, with unrepaired double-strand DNA breaks as a key lethal event. That injury triggers release of DAMPs, cytokines and chemokines, vascular leak, and acute inflammation. Cells may repair, die, or enter premature senescence. And senescent cells can contribute to chronic inflammation via the senescence-associated secretory phenotype, SASPs. These are a mixture of cytokines, chemokines, growth factors, and other mediators. Over longer timescales, these processes connect to vascular injury, fibrosis, and ultimately organ dysfunction. The paper also highlights evidence that preventing or clearing senescent cells can mitigate injury in animal models, and that candidate agents targeting these pathways are being investigated. Management is presented as explicitly multidisciplinary. For acute, self-limited effects, the emphasis is supportive care, reducing inflammation, treating infection when indicated, and symptom control, with early recognition improving experience and adherence. For late effects, that's often fibrosis, vascular damage, impaired wound healing, management again includes inflammation control, symptom relief, physical therapy, and sometimes surgery when other measures fail. And the authors note that guidelines do exist for several late toxicities. Figure 4 is best read as a representative map. It spans mucosal, GI, urinary, skin, pulmonary, CNS, cardiac, and sexual health domains, rather than as a substitute for clinical guidelines. The review is realistic about prediction. Rare radiation sensitivity syndromes increase risk. GWAS have identified regions linked to toxicity, and prospective studies are ongoing. Functional assays, ex vivo DNA repair or cell death after a test dose, and circulating cytokine approaches have been explored, and multi-omic strategies are an opportunity, but the authors are explicit. For most patients, predicting individual risk beyond dosimetry and known clinical factors is not yet really achievable. Figure 5 explains adaptive radiotherapy in a workflow way. Anatomy changes between fractions, position, weight loss, tumor shrinkage, variable organ filling, and motion during treatment can create underdosing of tumor or hotspots in normal tissue. Daily imaging can fix alignment, but when anatomy differs beyond a threshold, a plan change is needed. Online adaptive approaches replan and perform QA while the patient stays on the table, but they're resource intensive and require real-time team availability. Offline approaches allow replanning without real-time staffing, but can introduce delay or breaks. The paper then touches 2 investigational ideas. Pulsar is presented as a personalized ultra-hypofractionation stereotactic adaptive approach with longer intervals between fractions, aiming to capitalize on tumor shrinkage or other biologic changes, reduce breaks in systemic therapy, and potentially enhance immune modulation in combinations. And flash radiotherapy, defined here as ultra-high dose rate irradiation, greater than 40 gray per second, is described as showing preferential sparing of normal tissues with tumor killing in preclinical work, with an uncertain mechanism and early clinical feasibility reported. Importantly, the review emphasizes that benefits relative to standard approaches are uncertain and need clinical trial evaluation, obviously, at this stage. The authors are optimistic about personalization, but also clear about where the evidence is still emerging. Prediction remains limited, and newer delivery paradigms still need trial validation. So the headline is Radiotherapy toxicity is increasingly controllable because precision has reduced normal tissue exposure, biology is clarifying injury pathways like senescence and chronic inflammation, and the next frontier is integrating imaging, omics, and adaptive workflows to personalize both efficacy and safety. Now, one thing this review doesn't do, because it's just not that kind of paper, is walk through the experimental models used to study normal tissue injury. But it's worth briefly unpacking how this biology is actually worked out, if nothing other than because that's my area of interest personally. So historically, much of what we know about radiation-induced normal tissue damage comes from animal models, so particularly mice. These systems allow researchers to control dose, fractionation, and timing, and to follow tissues over months to years, which is essential for studying late effects like fibrosis or chronic inflammation. That's how links between radiation, stem cell senescence, inflammatory signaling, and progressive tissue dysfunction were first established. You simply can't observe those mechanisms directly in patients. Now, at the same time, the review also points towards a future where we need more human-relevant models, systems that can capture patient-specific susceptibility and cell types. Systems that can capture patient-specific susceptibility and cell type-specific responses. While not discussed explicitly here, that's where the newer 3D models like tissue explants or organoid systems that I'm very biased towards because it's what we work in, are increasingly being explored alongside animal work. The key message I would take home from this is that understanding radiotherapy toxicity isn't just a clinical problem, it's very much an experimental biology problem. And the models that we choose shape the kinds of mechanisms we're able to see. So, one of the challenges in studying late radiotherapy toxicity is that the field itself has moved faster than the biology. So, fractionation schedules have changed really quite dramatically over a short period, particularly in prostate cancer, which a lot of this review focuses on and a lot of my own work focuses on. And so I know, as do the authors here, that the patients with the longest follow up time were treated using regimens that are no longer the standard clinically. So if we want to look at long term biological effects in those patients, or even long term clinical effects, they're just not really relevant to the current cohort. This is a problem that we come up against in my own research too. At the same time, the patients treated with current approaches, they just simply haven't been followed long enough to fully characterize late effects. So preclinical models are essential here for understanding mechanisms, but they can't fully recapitulate human fractionation or decades-long tissue aging, and direct sampling of normal tissue over time, of course, isn't ethically feasible. I'm not going to say to a patient, hey, we're going to take biopsies from a healthy next-door organ for a few years after your treatment. It's just not remotely reasonable. So what we're often studying in reality is not really a perfect mirror of current practice. And the biological principles that are likely to persist across it, that's where combining models, clinical data, careful interpretation, and I guess interpolation as well becomes essential. If you're newer to reading reviews, this is a strong example of what good looks like. First, the scope is clear. Normal tissue effects as the boundary condition of radiotherapy, with a deliberate bridge from clinical framing to biological mechanism and back to management and future directions. So that's bedside to bench to bedside. Second, it uses figures strategically, one figure for technological evolution and dose volume thinking, one for organ architecture logic, one for mechanistic timeline, one for management as a systems map, and one for workflow innovation in adaptive radiotherapy. That's a very teachable structure. Each figure advances a different kind of understanding. Third, it's appropriately calibrated. It highlights exciting directions, biomarkers, multiomics, adaptive and biologically guided approaches, but it explicitly states where prediction and newer delivery methods are not yet proven enough for routine claims. The take-home message from this review is not just what radiotherapy does to normal tissue, but how we've come to understand it. Late toxicity isn't a single effect with a single cause. It's the result of long-term biological processes that unfold over time and that are shaped by the models we use to study them. As radiotherapy techniques continue to evolve, understanding those shared biological principles, rather than relying on any one historical regimen, becomes increasingly important. It's a bit new for me doing a review, but if you found this one useful for studying, researching, or teaching, the full paper is linked below. And in particular, I'd like to hear from you. Do you think I should do more reviews or stick to original research? Let me know. I'll see you in the next episode of Further Reading.